Hello again. Today I want to show you a case of an endoscopic intermuscular dissection. The patient was an 84-year-old with ischemic heart disease and a bypass graft done 10 years ago, as well as atrial fibrillation on apixaban. He presented with PR bleeding, and a colonoscopy revealed a 30mm sessile lesion with a central depression and advanced surface features located in the lower posterior rectum. Given the invasive appearance of the lesion, it was biopsied and these came back as adenocarcinoma. We therefore performed preoperative staging with MRI, endorectal ultrasound and a CT scan, which yielded a borderline CT1-T2 N0 M0 lesion. The case was then discussed in the MDT, where given the borderline staging and the patient's overall frailty, the decision was made to proceed with the local excision technique. The patient was scheduled for EID with curative intent, but failing that, it would at least provide definitive staging. Now, I imagine some of you will be wondering why we didn't go for TAMIS or TME, so I'll come back to that question as we go through the procedure. So here's the lesion. As you can see, it's a 3 centimeter sessile lesion with a small central depression. There's a fair amount of spontaneous bleeding and fibrin coating the surface, and on close-up the surface pattern is completely obliterated. So this is clearly a JNET 3 lesion, which is highly suggestive of deep submucosal invasion. It's important to mention that optical diagnosis alone cannot reliably distinguish between deep submucosal invasion and a T2 or even T3 lesion, and that's why we always perform MRI before committing to a plan. But even MRI has its limitations, as we saw in a very good paper published in Endoscopy last year by Schee and colleagues, which I will link in the description. Even expert radiologists, when reviewing MRI for EID suitable lesions, had a diagnostic accuracy of about 77 to 81%. Okay, so we're injecting now. As you can see, we're starting well away from the lesion itself. We're doing this deliberately in order to build a wide and stable pocket in the healthy tissue before we actually approach the intermuscular plane. The idea being that a stable pocket will give us the necessary counter traction and working space so that we can enter the intermuscular plane safely and with more control. The technique starts identically to standard ESD. We create the initial mucosal incision and then begin submucosal dissection, carefully coagulating vessels as we go to keep the field clean and maintain optimal visibility. So as expected, the submucosal plane is now narrowing, and that's our signal that we're approaching the target area. Now, there are different schools of thought on exactly when to enter the intermuscular plane. I know the Dutch group, led by Moons and colleagues, advocate entering before you reach the invasive front. Our approach here is slightly different. We advance until we see the muscle retraction sign, and at that point we withdraw approximately 1 centimeter proximally and make our entry into the intermuscular space from a position of stability. So we're just trying to widen the pocket here by opening up the sides a little bit. This is done mainly to ensure that we have sufficient maneuverability once we're inside the intermuscular plane. You can clearly see the muscle retraction here now. At this point, there's still some submucosa on the sides, but there's not much benefit in dissecting any further here now that we're committed to the intermuscular plane. So what we do is position ourselves directly under the lesion, then withdraw approximately 1 centimeter from here, and from that position we look for a natural opening between the circular muscle fibers and inject into that space to begin our intermuscular dissection. If you're positioned far enough back, the tissue between the muscle fibers actually lifts quite nicely with injection. Here we're using the same solution as we used for submucosal injection, which is a mixture of gelifusin, epinephrine, and a small amount of indigo carmine. Some people don't use the indigo, but I think it's quite useful to contrast the muscle with a small amount of connective tissue in between. And as you can see, we're now performing a selective myotomy of the circular muscle to open up the intermuscular plane. Once the myotomy is complete, we can now dissect in the intermuscular space. It's a pretty similar principle to standard ESD, but we're now working between the muscle layers instead of in the submucosa. You can see the circular muscle on top and the longitudinal fibers underneath. We like to use a short knife here for precise control, and since we're sacrificing the circular muscle to achieve our goal, we keep the dissection plane as close to it as possible and trying to spare the longitudinal fibers beneath. So now we've switched to a conical cap. This is the Fuji DH30GR, which is a 7mm tapered tip, and which in a narrow intermuscular space actually works quite well, often better than the straight cap. So the conical geometry engages tissue quite effectively and allows smoother advancement, especially when maneuverability is constrained. We then inject a little bit more solution to open up the space and continue with the intermuscular dissection. As you can see, progress here is slowing down. The intermuscular plane is gradually narrowing, and as we advance under the lesion, the muscle fibers are becoming increasingly difficult to delineate. So we're starting to suspect that there may be some longitudinal fiber involvement here. Okay, so it's quite obvious now that we've lost the intermuscular plane under the lesion. So this brings us to a critical decision. Do we now stop or do we continue? So in this case, my reasoning for continuing was the following. I thought the field is clean, there's no active bleeding, we have adequate time, and we're in a safe anatomical location, which is the lower posterior rectum. And most importantly, completing the resection would give us a specimen with definitive histology and margin assessment, which at the end of the day is the information that the MDT needs to make the right treatment decision. So in the end, I decided to proceed. Going back to the question I posed at the beginning of the video, why did we pick EID rather than TAMIS or TME? Both are clearly legitimate options for early rectal cancer, but I think neither was ideal here. TAMIS achieves comparable R0 rates to EID, around 90 to 95%. But it does require GA. It's a full thickness resection that opens the pararectal space, which then can have consequences for rescue or salvage surgery, and it's considerably more expensive. The DSE TAMIS randomized controlled trial published in Gastroenterology 2025 compared ESD with TAMIS and found costs nearly double for the surgical approach, with longer hospital stays, higher rates of late complications, and lower technical success. And since EID and ESD are closely related procedures, I think we can reasonably infer that there's a similar cost disadvantage for TAMIS when compared to EID. And finally, as regards to TME, which is clearly the gold standard for T2 disease, well, this carries even greater risk. The surgical morbidity, which is often quoted for rectal resection, is roughly around 30%, with a 1% mortality overall. So I think in an 83-year-old with ischemic heart disease, prior CABG, AF on anticoagulation, that risk profile is simply not acceptable as a first-line option when a less invasive alternative exists. EID, on the other hand, is performed endoscopically under deep sedation. It preserves the integrity of the rectal wall and keeps all future surgical options open. We also have the 3-year outcomes data from the Dutch group showing that cases with deep submucosal invasion and low risk features, which were managed with active surveillance after EID, of these 95% avoided rectal surgery at 3 years with 0 cancer-specific mortality. For deep T1s with intermediate risk features, 75% avoided surgery. So just to be clear, these are patients that would have likely not been cured with standard ESD, but that were nonetheless spared from radical surgery without compromising oncological safety by performing an intermuscular dissection. But I do want to emphasize something which is equally important. EID should be understood as both a therapeutic and a staging procedure. Among all the completed procedures in that same series, 16% revealed non-invasive or SM1 histology, meaning that EID actually overtreated these cases, and conversely 31% showed PT2 or deeper invasion. So really only 53% were true deep T1 cancers, which are the intended target of EID. But the crucial point is that in every single case, EID provided definitive histological staging that optical diagnosis and MRI simply cannot, and that staging information is what ultimately is going to drive every management decision that comes next. Okay, so back to the procedure. As you can see, progress in the pocket is slowing. We're working in a very confined space and dissection is becoming a bit laboured. So at this point we make the decision to open up the circumferential incision and try and restore working conditions in an open field. For this we decide to switch to the IT2 knife, which as you can see is much faster during the mucosal incision. And once we've opened up the sides, here we're doing the gravity side. You'll see we also use it to perform selective myotomy, which we're doing here with the safety of the ceramic tip, which will help us protect the longitudinal fibers. Now, because we hadn't separated this area so well from beneath, the IT2 knife was actually hindering more than helping us more at this point. So we switched back to the Pro knife, and in order to cut all the circular muscle here. One advantage of the intermuscular plane is that it's relatively avascular. There aren't really that many bleeding vessels here. What you do have are the larger penetrating vessels that can then branch into the submucosa, but if you identify those and avoid them, then you can usually cut safely with a cutting current. As we advance, as you can see, we're having to sacrifice some of the longitudinal muscle fibers as well, so it's a partial myotomy to free up the lesion. But notice that we're doing this carefully. We're trying to see clearly each fiber that we cut, and the goal is to complete the resection without actually breaching into the pararectal fat or creating a full thickness defect. So again, progress is slowing down, so we decide to switch our strategy once again, and this time we've decided to place a clip band traction. As you can see, we now have a much better exposure of the planes beneath. There is some charring from using coagulation current whilst cutting through the muscle. That's expected, but on the side here we've got a bit of remaining submucosa we still have to dissect, so we can probably use this traction to complete this whole area here. And once that side of the lesion is done, we'll reposition another traction to expose the anal side of the lesion and continue with the dissection. Okay, so we're now at the final stage of the procedure. As you can see, the traction is quite literally doing all the heavy lifting here. It's pulling the tissue away cleanly and giving us excellent exposure of the resection bed. So we switch to coagulation mode at a higher wattage here to seal any small vessels and prevent any residual bleeding as we complete the disconnection. And here's the final defect. As you can see, the lower portion is where we performed standard submucosal dissection, the pocket and the flap. You can then see a clear horizontal demarcation line. That's where we transitioned into the intermuscular plane. And above that you can see the longitudinal muscle fibers which are exposed, and within that area there's also a deeper zone where we had to sacrifice some of the longitudinal muscle to free the lesion completely. Following the Dutch group's recommendations, we usually leave the defect open without closure, and we haven't had any issues with this. The patient then received a short course of prophylactic antibiotics, was admitted for 24 hours observation, and was discharged with no complications. And here's the final specimen, a pathology confirmed, a well-differentiated adenocarcinoma with clear lateral margins but a positive vertical margin due to involvement of the partially represented longitudinal muscle. Lymphovascular and paraneural invasion were absent and tumor budding was intermediate. So despite a relatively favorable biological profile, this is at least a PT2 longitudinal although PT3 cannot be definitively excluded. In other words, we're dealing with a significant risk of local recurrence and lymph node involvement, which is well above the threshold required for TME. So the case returned to MDT, and after careful discussion, the patient was counselled on his options and finally chose to proceed with surgery. So I want to close with a brief reflection, because I think there are a couple of learning points that perhaps a straightforward curative resection would not have provided here. Now clearly this case did not go as planned. First, the intermuscular plane was lost, meaning that we had to adapt our strategy in real time. And then pathology revealed a tumour that was beyond what initial staging had suggested, leaving us with an R1 resection. Now I can see how that might sound like a series of failures, but EID did give us an en-bloc specimen with definitive tumour biology and depth of invasion, leaving the pararectal space intact. So it therefore provided a staging assessment that MRI and optical diagnosis simply could not, and that's what ultimately allowed the MDT to make a justified and evidence-based decision. So not basing it on imaging probability, but on actual pathology. And I do think that distinction is very important. We shouldn't really commit someone to radical rectal surgery based on a borderline MRI. We should do it based on what the tissue actually tells us. And that's exactly what EID provided here. So anyway, that's all from me. Thank you very much for watching. And if you found this useful, please don't hesitate to share it with your colleagues. I'll see you next time.